All right, this is Brian Wormers recording a lecture from Medical Surgical Nursing, talking about care of the patients with skin disorders. This chapter is going to be a lot of visual markers in relation to dermatological problems. Here are your learning objectives. Patient-centered care, so xerosis is one of the terms for dryness. Things that people can do for this: avoid soaps with antimicrobials or perfumes, as well as apply moisturizing soaps and creams and lotions to those dry areas. People can also get a lot of pruritus, which is itching, and big things that we can do with that one is emphasize proper bathing, giving oatmeal baths, warm them up, trim fingernails or cover their hands with soccer mitt, especially when they're sleeping so they don't scratch it. And we can give antihistamines to reduce itching. Sunburns, I'm guessing everybody's received a sunburn. It depends on how deep it goes. This one's blistering pretty bad. But things that we can do with that one is cool baths, soothing lotions such as aloe vera. They even make some that have got a lidocaine component to it to try and numb that skin up a little bit. If it's severely blistering, you might even do antibiotics to try and prevent secondary skin infection. Hives or urticaria, as in this picture here, are caused by an allergic reaction to something. And so things that we can do is, of course, remove whatever's triggering that, whether it's antibiotics, new meds, new cologne, new soaps, etc., and then treating with some antihistamines, usually like a Benadryl. Skin trauma. So the phases of wound healing include inflammatory, and then you've got proliferation, which is repair of that connective tissue, and then remodeling and maturation. Mechanisms of that wound healing would be first intention. So if it's without tissue loss, like a skin laceration, the edges are just brought together, and we can glue that or we can suture that nicely. Second one is like a pressure ulcer, and this is when you've got tissue loss, and you're going to have to gradually fill in the dead space from the outside in. And then you get third intention. So this is a high-risk one. This is like surgical incisions that are infected and oozing. And in this one, you've got to leave them open and then debride them out, and so that they can go into that secondary intention where it heals from the outside in. Partial thickness wounds, so this is epidermis and dermis. So usually heals up. It's kind of a scrape type of a situation. It heals up in 5 to 7 days. This is pretty easy. Full thickness is going through all of those cells, and then, like I said, it's got to fill from the outside in. Pressure injury, this used to be called pressure ulcers, but now we're using the term pressure injury. So this is tissue damage when the skin and the underlying soft tissues are compressed, usually by a bony prominence or something that was hard. But it can occur on any surfaces. Some of the main things that we'll look for will be on the back of the heels, on the coccyx, on the sacrum, on the spine, on the elbows. But you got to realize that there's lots of mechanical forces here. And so we've got, shearing force of the body going down against gravity. We've got friction of the bed. We've got shearing where that skin is not moving. We've got bunched up friction here. So we can see all these different shearing forces at play. So pressure injury prevention, we're really trying to identify. We've got different risk scales that we can use. We do nutritional assessments to make sure that they've got enough hydration and enough protein. We want to do mental health changes and see if there's anything that's changed on this patient. Can they recognize that they'd be at risk? If they are incontinent, that puts them at higher risk. Diabetes mellitus, of course, if you've got decreased circulation to an area as well as increased thickness of that blood. Peripheral vascular disease, so they're not getting good circulation to that skin. Once again, those can all be big risk factors. So what do we do with this one? Try to do pressure relief devices. This could be different types of beds, different types of mats, different type of gel pads, etc. We can do pressure mapping. I've seen this used extensively with wheelchairs, and where are those quote-unquote hot spots that people are reacting to. And so this is some of those relief products and devices. Positioning, make them move at least every 2 hours, if not more. And then make sure that we've got the heels and pressure free, and all those high pressure areas are moving and protected. So contributing factors: prolonged bed rest, we've got immobility, incontinence, diabetes, so all these things that we kind of talked about before. So stage 1, you've got a reddened area, but the skin is intact. Stage 2, skin is not intact. You've got some breakdown, but it's partial thickness through the epidermis and dermis. Bruising is not necessarily present at this point. Stage 3, full thickness, where you lose all the skin. You're seeing the tissue underneath. That tissue and that fascia may be damaged or even necrotic. At this point in time, bone, tendon, and muscle are not exposed. With this, you might have undermining tunneling, meaning that through the skin and underneath, you might have pockets. So you could put like a Q-tip and it'd go for a ways underneath that skin. Stage 4, so full thickness, and then it's exposing muscle, tendon, or bone. Of course, you're going to get some undermining tunneling with this. And then often you get some eschar and some sloughing of that tissue. So when you're doing wound assessments, make sure that you're documenting it well. So what I mean by that is, where is it at? Be very precise with that one. What's the size? Don't say it's the size of a quarter or something like that. Actually measure it out using centimeters and millimeters. Look at the color of it. Look at any tissue that is involved with this. What kind of exudate? Is there drainage from it? Look at the surrounding tissue. Is that at risk? And is there any foreign bodies within that? So a wound is always contaminated, but it's not always infected. So the fact that it's open to air and it's open to things that can make it sick, there's going to be, you all know that you got microbes on your skin and such like that. So we've got microbes in that wound as well, but it's not always causing a problem. So once it is, then that's called an infection. So we can't have contamination, so it's organisms without an infection. Otherwise, it can be an infection, and that's when it's causing problems. Non-surgical therapy, so physical therapy is great with us. We can use whirlpool treatments, dressing changes, and even like a wound vac and rinse it out. We use drug therapy, so treating of infections. We can use antimicrobials, and we can even use some chemical debriding on that. Nutritional therapy, they've got to get enough calories to fix themselves, including protein, vitamins, minerals, and water. So some are new technologies, so we can use vacuum-assisted wound closures or wound vacs. We can use hyperbaric oxygen. We can use topical growth factors to try and get that skin to heal better. We can use skin substitutes, so it can kind of make a matrix and grow upon that. And then we can actually even run a current through that, which has been proven to stimulate the growth of cells. If these are not working, then we can go into surgical. We can debride it, either physically with the knife, or we can do chemical, and then we can do skin grafting and muscle flaps and different things like that. So moving on to some bacterial infections. This is folliculitis. So this is an infection of the upper portion of the follicle. So you can see this, often called shaving or hot tub folliculitis. So to me, this looks like one great big cesspool of bacteria. So I'm not sure if any of you are in this picture, but just keep that in mind. Furnicle is just a little bit deeper, so it's a little bit redder, a little bit more of an infection at that site. Cellulitis, you can see the outline of this, where it's red, and this is usually staph or strep, but it's deeper than just the topical skin. So treatment of any of those bacterial things, of course, is with antibiotics, and that's your mainstay of treatment for those. So herpes zoster or shingles, so this is a secondary reaction after somebody's had chickenpox. It always goes in a linear line, so that's one of the key defining features of this. This often hurts. It causes some nerve pain, and so the pain can be severe. So treatment of this, of course, if you catch it early enough, you can use some antivirals, but then also pain medications. So herpes simplex virus can cause open wounds like this. Once again, antiviral medications. And so here's some herpes simplex type 1 as well. Can get fungal infections, so especially around the nail beds. Can get fungal up on the scalp, so tinea capitis, so think cap for the top of your head. And so this is causing the hair follicles to die off and the hair to fall out. So Tinea corpus, so otherwise known as ringworm. So you're seeing these stuff right here. And another fungal infection would be Candida albicans or thrush. So for any of these, you want to give antifungals. So for the other stuff, it could be topical nystatin. This would be oral nystatin. You can do stronger antifungals, but you usually start with something less invasive. With the Tinea capitis, you might have to go with the ketoconazole, but that will be at the provider's discretion. So interventions for common skin infections. So generally speaking, clean the skin, isolate that wound to make sure it doesn't get passed on. Antibacterials, antifungals, and anti-inflammatories, as we kind of talked about before. Pain meds. Parasitic disorders, so lice, so Pediculus capitis. Once again, you get scabies, which bury into the skin and track. This causes, it's not the bug that hurts, it's when they have excrement in there, and that's what causes the itching. And an easy way to check this is to put a marker over the site, and if you see underneath the skin, you get some black lines going along that trail. That can be indicative of scabies. And then the last one here is bed bugs. So with all these insects, of course, we want to give the anti-insecticide medications and clear that up. And generally speaking, that's going to be a bigger task. So you want to treat the patient, you want to treat anything that they've been in contact with, you maybe even want to treat the whole family so they don't pass it back and forth. And these insects will spread quite rapidly. Eczema is another common thing. You can see this one on the foot as well as this pustular one on the hands. Contact dermatitis, so nickel allergy, the watch band, on the eyes here, around the neck, around the foot. I'm trying to think of what that is. Atopic dermatitis, so around the knees, right here. Psoriasis around the knees. Psoriasis vulgaris, so widespread. So treatment of psoriasis is going to include steroids to calm that body down. This is one of the interesting things that we can use tar as a preparation for that and place it on that. We can use ultraviolet light, trying to dry that skin area up, and some systemic therapy like cortisones. And then, of course, emotional therapy, because this can have a great impact on your psychological well-being. We can talk about tumors. So we've got seborrheic keratinosis and a keloid. Keloids usually happen after some kind of an injury, and then you get an overgrowth of the cells. I've seen this commonly in surgery. We can also talk about sebaceous cysts. So you get kind of this underground sebaceous cyst. Up in the eyes is a very common thing, or on the face, or wherever this one's at. Usually these require surgery because you've got to get the whole thing out. If not, then it comes back. Pilonidal cyst. So this is on your posterior side, and this is your butt, and just at the top of your butt crack, you've got an area in which you can get ingrown hair, and that can be like a remnant from a tail, is what they're theorizing it. Once again, this one has to be surgically treated too, otherwise it will keep coming back. Skin cancers. So we can talk about facial skin cancers, so basal cell carcinomas, melanomas, all these fun things. Management of it, of course, prevention is huge, so being out of the sun, using good sunscreen, using good hats, and then treatment of it, surgical, so freezing it, cutting it out with electrodissection or with a knife. Mohs surgery is progressive removal of skin layers until you get clearing on your slides from pathology. And generally speaking, you make a wide excision just to make sure you've got all of it. Can try drug therapy and radiation, but generally speaking, I've seen more surgical interventions of this. Stevens-Johnson syndrome, which is a common and very serious form of drug reaction that you guys have read about in your textbooks, and TENS, which is very similar to that, and this could also be a drug reaction. This concludes this presentation. If you have any questions, please talk to your professor.